Hello, I'm George Liston, CA. Welcome to Dialogue, a program that explores the world of ideas and issues in international affairs, history, and culture. Public healthcare policy occupies a unique place in the political spectrum of any country. No subject offers more striking evidence of a society's relationship to its citizens. Healthcare is a barometer of what a nation means by quality of life, and an indicator of its level of concern with issues like equality and inclusion. Because healthcare policies reflect not just current politics, but also history and core national values, comparisons, where appropriate, can greatly improve our understanding of what is at stake. A comparison of the healthcare of France and America, for example, can be extremely rewarding. Working from shared basic values, their practices have diverged greatly, although some common challenges may lie in their futures. My guest is Paul V. Dutton, author of Differential Diagnoses. Paul, welcome to Dialogue.
Good to be here, George.
It's great to have you, and I really enjoyed reading. Let me hold it up now for everyone to see. Differential Diagnoses, which does in fact examine the healthcare systems of these two countries. And right from the start, Paul, I think it's this business of shared values at the basis is very important. I want to get your comment on it, that these two sort of modern versions of Enlightenment values, liberty and equality in France and America, influence the systems.
Well, they do come from the 18th century revolutions, I think, and there's tensions between the two from the very, very beginning.
Right.
And in terms of healthcare, the values, you see them in really three areas. Maybe we could talk about these more
Sure, we'll
later.
just list them right now.
The first one, of course, is patient choice.
Right.
I think both the French and Americans want to choose their own physician or other healthcare provider. The second, of course, are the physicians. They want medical practice freedoms, clinical decision-making, control over it, vis-a-vis the insurer. And then the third one has to do with who are the insurers, really.
Right.
And this is where the history becomes very, very interesting, because the French, of course, now have a large public insurer, complemented by many private, and we have a mirror image of sorts.
Yeah.
But if you look at historically, in the initial phases, the French opted for private, not-for-profit insurers, that sort of civil society organizations, which are still very important in their system.
You know, I'm very glad that you bring out those basic lessons and those three commonalities, or those three shared concerns in both systems. And one thing in particular, Paul, I was struck by this in reading this book, when you mentioned the influence of physicians. Fee-for-services have been a vital and protected value in both societies, is that right?
Absolutely. I mean, that dates all the way from the 1910s and the 1920s. In the American case, the physicians were challenged in 1916, 1918 with an effort to create compulsory health insurance in this country, in a state-by-state effort. That failed. Rallying physicians to oppose that, though, really served as a foil for them to stand behind fee-for-service medicine, physicians as professionals. And the same happened in France, very interestingly, in the 1920s. They, too, were challenged with an effort to create compulsory health insurance, but they ultimately cut a deal. They cut a deal by which the physicians said, yes, we will sign on to this, we will cooperate with compulsory health insurance as long as our clinical decision-making is protected and physicians have free choice of practitioner.
This is an extremely important point and reached in the early part of the 20th century, and we're going to examine it in some detail. But just to dwell on this notion of fee-for-service being essential to both systems, although the French will move to a different sort of expression of it. Maybe we should address one of the great challenges, or one of the great criticisms made in this country about French healthcare. And to put it bluntly, it is not socialized medicine, is it?
No, well, it depends on what you mean by socialized medicine. I mean, if you mean by socialized medicine that the government pays for more than half of the health care, well, then I guess it is. But then, wait a minute, then America has socialized medicine as well. Because right now, the federal and state governments, the Indian Health Service, the VHA, that is the veterans programs, pay for about 46% of our health care.
Right.
And if you count the tax deductibility of health insurance premiums, well then, which is a form of government subsidy, then more than half of our health care costs are being paid by the government. So it depends on what you mean. If you're talking about a definition of socialized medicine, though, in which you're talking about whom the doctors work for and other healthcare providers, then, of course, the French do not have a socialized
That's right,
healthcare
because a French person can go to the doctor of his or her choice
right.
and pay directly, and then
Exactly.
be reimbursed by the state for 70 or 80% of that
That's
charge.
exactly right. The vast majority of ambulatory care physicians in France are private practice, fee-for-service practitioners. The hospitals are a different case. Most of them are in the public sector, but still France has the largest private hospital sector in Europe, about 36% of all beds.
Paul, as you mentioned just a moment ago, it was in the 1920s that France began to move toward compulsory health insurance.
Yes.
And you made a very important point that I think we should come back to right now, and that is the role of the French doctors in reaching what I think many call the grand bargain, accepting that. And from the book I got the impression they adopted a basically centrist approach. If there was going to be such a thing, they wanted to be a part of it.
Right, yeah.
Tell us about their attitude and contrast it with the attitude really throughout the century of the American Medical Association and American doctors.
Well, I think that the French doctors, I mean, it was a huge schism in the French medical profession. In fact, their version of the AMA actually split into 3 different organizations over this very battle. So it's not as if the French doctors, keenly said, "Oh, we have no problem with this. We'll just make a compromise." No. It was after actually years of debate. They finally said, "We will make this deal,
right,
as long as we make sure that patients still have choice, and we as physicians still have control over medical decision making, and of course, medical confidentiality." Was something they wanted to protect. And then lastly, as you said, they wanted fee-for-service to be not just sort of the professional ethic, but actually legally bound. And when certain insurers tried to violate that, they took them to court. They went to the legislature.
Now, by contrast, Paul, and that's all extremely helpful, but by contrast, I was struck as I read this book that in the same period of time, when this issue, of course, came to the fore over here, and correct me if I'm wrong, I got the sense of massive rejection. The doctors, the insurers, but even labor unions were, quote, socialized medicine, didn't want a part of it. Is that right?
At the time, let me start with the last first. Samuel Gompers was the president of the American Federation of Labor. And he was an individualist. He was sort of a rugged individualist labor leader who wanted, of course, health security and health coverage at some level for his workers. And by the way, the French case, the bill that was being considered in the 20s was only to cover industrial workers.
Right,
so it's very comparable, though, because Samuel Gompers, AFT president, AFL president, really insisted that workers should control their own health insurance organizations. And so he opposed it. And of course, those on the right who've just pointed at Samuel Gompers and said, this isn't a bill for labor because the biggest labor union is against it, you see. So, and at the same time, doctors, they wanted to rely on their political muscle to protect their professional sovereignty. And they didn't want to go to the legislature. And this really, if you don't mind, I'll just kind of belabor this just a little bit, because it goes back to your starting question about liberty and equality. The French state is more important in the French case, and that citizens there, because of the nature of the 18th century revolutions, and if you look at them, right, you look at the American Revolution in the 1770s and the French Revolution of the 1780s and the 1790s, when the revolutionaries came to power in France, they had to use state power to create equality, to come back. And whereas in the United States, it was not a society so soaked in aristocratic privilege. Now, of course, the great caveat is the slavery of Africans in the South, which American revolutionaries chose not to deal with at that time.
Well, on that very point, and this is another of the major themes of this book, and I was struck by it, I never really thought about this, because the history of healthcare in America, also in the sense of liberty and equality, reflects the questions of who is excluded systematically from it. And I mean, and you make major points about the exclusion of African Americans in a variety of ways from the system as it evolved, either explicitly or as a result of the professions or the work, the agricultural work they were doing in places in the country.
Exactly, and that occurs from the very beginning. Perhaps some of the most notable cases, I think one of the reasons why the Social Security Act of 1935 did not include health security was because Southern legislators who were ideologically, they weren't as far left as Franklin Roosevelt, did not want a federal program covering health care that would violate the state's rights, and imposing those, and the federal government would be involved in granting African Americans health security.
You know, you bring me right to the point I wanted to be in our discussion, because having talked about the 30s, the first grand bargain in France, the move to compulsory health insurance, resistance to that in this country, an obvious question is, during the Depression, when, you know, deprivation was such a major national issue, why didn't we get in the New Deal health care? And you point out the Southern opposition.
Yes.
And was there a sense in Franklin Roosevelt's mind it was just too big a fight to take on?
He was not willing to risk the political capital. I mean, he had a major portion of the business community was willing to go along with Social Security, what we call Social Security. That is pensions, compulsory pensions. And that's because it just involved, of course, a wage levy, but it did not involve the kind of intrusion that might have taken place if you had had health care involved as well. Doctors were another reason, again. We come back to the physicians. The American Medical Association by the 1930s was very well organized and capable of fighting off a compulsory health insurance bill.
By contrast, during the Depression era, that decade preceding World War II, what was going on in France?
In the 1930s. Well, they had passed their first compulsory health insurance bill in 1930, and what they had done was, it's actually part of this second half of the bargain that you mentioned, is that these not-for-profit insurers, what are known as mutual aid societies in France, actually they opposed the bill until they were given a deal, and that was that the mutual societies could serve as insurance carriers. And that was very beneficial, I think, because...
How should we think about those mutual societies? What do they correspond to in American?
Well, they're really a couple things. You might think about, certainly in the early days, you could think about them as being like fraternal orders of sorts. I mean, they're socioeconomic, they're socio-professional. Oftentimes, in the vast majority of cases, were like fraternal orders, limited to men. And they were like small insurance clubs. And some of them, of course, grew very, very large. By the 1930s, but they were actually sanctioned by the state to offer coverage, and so this facilitated, and I think it comes back to my opening statement there about a similarity between French and Americans, is that they were both willing to trust, rather than the state, they were willing to trust these civil society organizations with, you know, directing and working the health insurance system.
During World War II, Paul, moving our story historically along, I got the sense of a lot of convergence in what both healthcare systems were concerned with. That is to say, you know, the sad fact of war is you need populations to fight them, and so just encouraging well baby programs and population growth was sort of the core of what they were concerned with. Is that right? Yeah,
that's absolutely true. I mean, in France, of course, you had a government in place in Vichy. It's known as Vichy. It was just based in the small town of Vichy. And they were collaborating with the German occupation forces, and they were trying to push children's health as well as population growth. So maternal health and prenatal health were very important to their programs. In the United States, you had, I would say, you had those New Dealers who were still wanting to do something. They saw an opening during the Second World War. They looked at the case of servicemen and women who are abroad, and they said, you know, we need to have a program for families. And so they created what is known as the EMIC.
EMIC,
Right. And so that program provided health care for servicemen's family, and then they also worked a lot in the rural areas to create health care.
So they were essentially making advances where they could in the hope that they would get more of a bigger pie for everyone. The post-war years, particularly I guess from 1948 to 49, seem to me to be absolutely pivotal to understanding our current situation. And here we get the phrase, the second grand bargain in France. And correct me if I'm wrong, but I got the sense the French moved the funding of their system to their Social Security, or Sécurité Sociale system. And this is a major, major advance. And it puts the French insurers in a different role to private insurers.
It does, but it wasn't, let me make this point clear, it wasn't revolutionary. because when the French had a choice, and this is really what didn't happen is also very important. It's a little bit like it's a little bit like the New Deal. What didn't happen in America was we didn't get health insurance with Social Security. What didn't happen in France in 1945-47 was that they did not create a national health service, which Britain did, for example, in which case the physicians who had been working previously under the National Insurance Act became much more closely tied with the state and started work on capitated lists. That is, you could sign up in a certain area for a physician, et cetera. The French, actually, when they had the chance, held on to their private fee-for-service, solo practice, ambulatory care physicians.
Right.
Yeah? And they also kept wage levies as the way to raise money. So the mutual societies, as you kind of implied there, they went to the back seat. In other words, they were no longer the principal insurance carriers. Sécurité Sociale became that. However, the mutual societies stayed in the game, and they're important to this day because they serve as supplemental insurers.
Exactly.
So if you go in for I don't know, ear infection, let's say a sort of a low acute, ambulatory care case, and you have a physician's visit, you're going to be paying 70%, Sécurité Sociale is going to pay 70%, you're responsible for 30%. But if you're one of 86% of the French that have this supplemental insurance, then the mutual, in most cases it is a mutual, will cover that remaining 30%.
So is this the era, or is it slightly after that, that one can effectively say that in excess of 96% of the French public is covered?
Now they're at full coverage since 2000.
Everyone?
Everyone, in one way or another. Yes. Yeah.
Another major theme, it seems to me, if not of the early 1950s, certainly of the second half of the century up to now, was the growing burden of cost on both systems. I'd like you to talk a bit about that, because it seems to me that one of the major challenges has been maintaining cost, but keeping costs down to the greatest effect.
Yeah.
But that's been approached differently in both countries as well.
Right. Well, there's similarities and there's differences. One of the ways that the French system, relative to the American, holds down costs is that they have a large public insurer, in which overhead costs are about between 5 and 6%. Right. In this country, private insurance companies spend a lot of money on actuaries and risk experience rating, risk class analysis, and their overhead is really hardly lower than 15, sometimes very much higher. So there's a lot of administrative costs, and I'm including in those administrative costs, of course, all of the billing complexities that providers face, and the French don't have that.
That was a striking section in this book, quite frankly. I was struck by it that, as you say, a French doctor has access to the computerized health records of everyone, and the pay system is just a matter of keying certain things in and getting it.
That's right. And so you have a single national insurer makes that possible. And Medicare actually has lower overhead costs even than the French Sécurité Sociale. I mean, they're running at about 3%. So that's one of the ways in which cost is controlled. Also, French medical professionals make less money than Americans.
This is another and they also face, and this is another point that I hadn't understood, less malpractice threat, or at least it's not as robust as it is.
That's right. I mean, I don't think it's a tort-averse society. I mean, it's not as easy to sue a physician, which means, by definition, then, is that the malpractice insurance premiums are much, much lower. And medical education in France, at least tuition, is non-existent.
One of the cost-raising factors, the cost pressures, is the rising proportion of elderly people in both societies. And I think that your book makes a very strong, gives a very strong explanation of what happened in this country in the mid-'60s with the advent of Medicare and Medicaid. And Medicare, as I began to understand the French system, seems to me almost like a wonderful American sort of image of it, or very comparable.
Yeah, I mean, there is something to that. If I only have 30 seconds to tell somebody what French healthcare is like, I say, well, it's like a Medicare for all. Because in that sense, you do have a single national insurer who is covering a certain age group in this country, and the members of that age group can buy supplemental insurance. Right? I mean, Blue Cross Blue Shield sells, excuse me, it would just be Blue Shield, sells supplemental policies to Medicare Part B.
Medicaid, of course, is directed to those who are impoverished.
Right, it's a means
But it seems to me that that's not as powerful.
No, it's a means-tested program. It's something that the French do use in some cases, because you mentioned earlier how they got to universal coverage. That they do use certain programs to help the indigent make sure they have coverage, so that they've been able to have 100% coverage.
Right. You know, the book very neatly brings us from the beginning up until the present moment, Paul. And turning to the sorts of problems that both systems face and what they might learn from each other, I'd like you to first explain this. The World Health Organization has ranked the French system #1 in the world and placed America 37th. Why is that so? And given that and the other points you've made about the evolution of these systems and their strengths and weaknesses, is there a fruitful dialogue to be held between these two systems? Are there things they can learn from each other? I mean, are there things the French could take from America as well as we from them? And
they have, but let me start with the first. I mean, the World Health Organization ranking of the French system was based on its universal coverage, its provider responsiveness, its cost, and its equity for the population. And they did very, very well on all those categories. The French are very healthy, they have good providers, there's a lot of responsiveness, there's no waiting lists for elective procedures and things like this. The American case, of course, is quite different. There's 16 million people without health coverage. There's many more who are underinsured. The costs are astronomical, really, even among rich countries. In the OECD countries, this country's spending right now just over $2 trillion a year. It's 16% of GDP. The French are spending 11.2% of GDP, third most expensive in the world, but still a lot different than the American. And they actually have experienced a slight decrease in healthcare spending as a percentage of their percentage of their GDP, according to the latest report. Now, you know what that means for sharing with each other. I think that the Americans can look, I think, fruitfully at what the French are doing with a national insurer. I think that if we look at certain proposals that are, for example, currently on the table by Democratic presidential candidates, they do include a public insurer option, which could grow into something. One thing that I think we have to be careful of as Americans, though, is the link with employment. I think that's where both the Americans and the French, in my own historical analysis, need to watch out, mend their ways, because this creates in this country, for example, if we don't have any sort of employer mandates and it's free to the employer to offer or not health insurance. Right now we have a very good study shows that between 25 and 45% of the American labor force is job locked because of health care. You take the job where you can get the health care rather than the job you may necessarily want to do. Right, or in which you're most productive. Right. And if I'm no economist, but I will tell you that if you have a country in which people aren't looking for where their skills match wage, not seeking the best place to put their skills to work, the standard of living of the country will fall. Is another point from this night, this is from me as a reader, Paul, is it about time for us to just jettison, get rid of this whole socialized medicine shibboleth that's been floating about, and recognize that government does have a role in our health care? You know, well, I think this has to be accepted. Very much so. I mean, I do think that it's a false question. It's a question that maybe made sense in the 30s or maybe as late as 1947, but it doesn't make any sense anymore, not given the statistics that I cited earlier about more than half of U.S. health care being paid for, financed by the U.S. government. So I do think we need to jettison it. And look at healthcare as a public-private endeavor, and just decide how much of a role we want the state to play without second-guessing it, without judging it, and how much it makes sense for the private sector to play. And that's where the French, 77% of their healthcare spending comes from Sécurité Sociale, right? 13% is coming from these private for-profit and not-for-profit insurers, and about 10% of healthcare in France is being paid for out of pocket. Now, so it's not free there. Exactly, and in paying for it, and this is another of the major points, especially toward the conclusion of the book, that I found worthy of a lot of thought. The need for a progressive income tax. Yes.
as a way of bringing the funds into the system
Yes.
that would make it work.
Right. I mean, that's where if you say, well, we're not going to pay for it at your employer, we're not going to pay for it on payday, then how do we pay for it? Well, I would suggest that we look at progressive income tax of some sort in which you can spread the burden across the population, get rid of this job lock, which is going to kill us in the long run.
Right.
Especially since healthcare spending is now predicted to go to $4 trillion by 2016. That's going to be 20% of our GDP. We can't have our employers and our employees looking at healthcare as the reason to offer or to take jobs.
I agree completely. I mean, I think that absolutely destroys the dynamism of an economy.
Right, it can.
If people are doing that.
Let me add one thing, though. I mean, I don't want to, and I didn't kind of finish the answer to a second question. I mean, the French are having trouble paying for their system, as are most industrialized countries, yes. And so they have about a $12 billion euro shortfall at the moment. And so they're looking for ways to patch that hole. However, I would say this, is that with their having covered everybody, I think they're in a better position to move forward than the Americans right now are still working on how to control the cost and cover everybody at the same time.
I appreciate that, Paul. One final note, and this is, again, my reaction to the book. It occurred to me, and we only have about a few seconds left, but getting doctors on board is another major challenge, because the attitude of the medical community throughout the last century may not have been as helpful as it could.
Yeah, I mean, I think that physicians in the United States more and more are looking for salaried positions in which they have more control over medical decision making.
Right.
And that's not something that decreasingly, I think, with the large managed care corporations, they're having trouble holding on to.
Right.
So that may bring them along.
Paul, you've brought me along. I thought the book was terrific, and I recommend it to everyone to read. Everyone, absolutely. Thank you, Paul Dutton.
Thank you.
And that's our program. We appreciate your comments, and you can reach us at dialogue@wilsoncenter.org. I'm George Liston, CA, and you've been watching Dialogue, a co-production of the Woodrow Wilson International Center for Scholars and MHC Networks. Dialogue is also on the MHC Worldview channel, which is available to public TV stations nationwide. For more information, go to www.mhcworldview.org. Please join us again right here next week, and thank you for watching this week. Paul Dutton, thank you very much.
Okay,
we did it.
Yeah, that was great.